Good afternoon, everyone, and thank you for joining us in this interesting symposium. We're going to be talking about the DK Score Pro balloon, innovation, evidence, and everyday practice. This is a sponsored session by DK Medtech. Some of you may never have heard about this balloon, but I'm hoping you're going to be intrigued when you see some of the clinical evidence and some of the usage and how this balloon is made. But let me start by introducing our panel. I'm co-chairing the session with Dr. Bin. Thank you for joining us, Dr. Bin. And then we have as discussants Antonio Colombo, who needs no introduction, Alfonso Jurado from Spain. If I get it wrong, please correct me. Bharat Kialani from Singapore, Louis Verral-Julian from New York, and Dr. Lau, who will also be giving one of the presentations. So the objectives really of this session is to really kind of think about lesion preparation strategies and what we do and how they may influence procedural outcomes, look at some of the clinical evidence, and then look at this new balloon in particular. So I had maybe just a couple of slides just to stimulate some discussion with you. So the one question I guess I often get asked is, do we really need specialty balloons? Do we need them in routine practice? Do we need them only for specific cases like restenosis, calcified lesions, fibrotic lesions? A lot of people are talking about specialty balloons more than ever because of DCBs as a good way to prepare lesions for DCBs. Maybe it even gives better drug penetration, right? I also want you to think about a little bit, because we'll bring it up in the discussion, is these balloons, are they something we should be using as intention to treat? Oh, I see, this looks like a lesion, I'm going to do a DCB, and let me just take a specialty balloon rather than a non-compliant balloon? Or are they only when non-compliant balloons fail? I also want you to think about the balloons you've used in your practice and maybe the ones you chose not to use, because they're not all the same, right? Think about deliverability of the balloon, think about compliance and the compliance charts, think about efficacy. For me, the other thing I look at when I look at these balloons is, can I inflate it at high pressure? Because I believe they really get effective when you inflate them at high pressure. And I was surprised. There's a lot of specialty balloons out there, right? I mean, look at this. These are just some of them, but they're all very different. And the details of how they work really impact the usability and how effective they're going to be. And I have to be very honest, maybe about 6 months ago, I'd never heard of this balloon, the DK Score balloon. But when I saw how it compares to some of the other balloons, I became really intrigued. And I'm so intrigued that, we're trying to figure out with the company how to do a study in the United States to get FDA approval, because I think this balloon has an important space. So I'm not going to go into the balloon. You're going to see from our speakers why this balloon may be unique. But again, I want you to think about this. My mentor over there, Dr. Colombo, said to me recently, specialty balloons, they call that because they're special. I don't know if that's because they cost more money. That's why they're special, Antonio. But there is data that with specialty balloons, you get better MLAs. Okay, they may facilitate drug deliverability, and I think they may also decrease bailout stenting and improve dissections when you're thinking of DCBs. So I'm going to stop there, and I'm going to let Antonio take it over and talk about how we think about scoring balloons in calcified fibrotic lesions and bifurcations. Antonio.
Thank you. Thank you very much, Azim. Azim asked a question, do we really need a specialty balloon? And I will have someone answer the question for Azim, not myself.
That the balloon catheter only. We need more than that. But for most of our problems at the present time, the balloon catheter is quite a good answer. But the more we depart, as I said, to more diffuse disease, the more we have to change our directions to additional catheter systems. Because the balloon catheter in the form it is done now will not really solve that diffusely diseased, chronic, sick coronary artery.
So 1982, he was much in favor of regular balloons, but he felt that something else was needed. So it took a while, but I think if Andreas was here, he will be pleased with this. So the first dedicated specialty balloon is a cutting balloon. And there are few randomized trials. I remember Raoul Bonan from Canada was a pioneer. The global trial was more than 1,000 patients before drug-eluting stent, before drug-coated balloon, before stents, and the cutting balloon didn't really work much. There was 30% versus 30% restenosis. There was a small vessel study, restenosis 31%, so even in small vessel did not work much. There was a trial published in 2010, reduce 3 trial was IVUS plus cutting balloon plus bare metal stent had a very low restenosis that time, and they even dare to compare with DS with 5% restenosis. The first author is Ozaki. So I don't know if it's really so dramatically better, but definitely encouraging. In 2004, our group did a study randomized for ISR versus standard angioplasty, no DCB, and the restenosis was a little bit 1% better. So the history of the cutting balloon before drug-eluting stent was not magnificent. So many studies shows only some advantage in complex lesions, but there was not a clear, definite study. We go recently, Antonio Mangieri did this small mechanistic randomized study done in complex lesion, calcified lesion, comparing a high-pressure balloon, non-compliant, versus cutting balloon with IVUS evaluation of the result. This is published in CCI. And there was some advantage. If you see the final cross-sectional area was 7.1, 6.5, not dramatic, but all the data were in favor of the cutting balloon. So these were complex lesions. So I think this established a possible role for these devices in this type of lesions. So a benefit of cutting balloon are evident in lesions with more than 27 degree of calcium if you look at the subgroup, but these are small number of patients. Still, there is some signal. We know that cutting balloon or specialty balloon are to be used, but not the solution. When you see such a big amount of calcium, you don't even dare to go with a balloon, specialty or regular balloon, you need rotablation. But when you see a lesion like this, especially in the circumflex, that we know how prone are these lesions to restenosis, even with good stenting, I believe a specialty balloon are needed. When you see a complex bifurcation, you may consider to stent the main branch, but this long diffuse disease diagonal branch, I think a specialty balloon will be appropriate. There is a randomized study of Dr. Gao in China, published 2 years ago, but this was done in simple bifurcation. We personally prefer to evaluate this strategy in more complex bifurcation. And this is, to me, is a typical lesion where a specialty balloon is needed. Ostial circumflex, where you want to minimize the use of stenting to avoid carina shift and to avoid late restenosis, which is not rare, as I said, even after good stenting, and this 1-year follow-up. This is not an anecdotal case. We have a big registry of 152 patients treated with DCB, 351 treated with DS, first author is Francesco Tartaglia. The 2-year rate of target lesion failure was 19% versus 19.8, so no difference. But this was with any balloon to prepare the lesion. But if we go in the DCB group, 27% of the lesions in this registry were treated with cutting balloon, so with a specialty balloon. And when the pre-treatment was done with this specialty balloon, the target lesion failure dropped from 33 to 22%. So I think, again, this is hypothesis generating, but I believe that in complex lesion, a pre-treatment with a specialty balloon prior to drug-coated balloon is valuable and needed to be tested in a prospective study. To conclude, another usage of this specialty balloon is to treat unfavorable result after PCI. Here you see a hematoma. The standard treatment here is to place a stent. The contrast fills is hematoma, but leads to compression of the true lumen. But after cutting balloon, the hematoma communicates with the true lumen, and you get a good result without the need to implant a stent. So this strategy can be utilized in a setting. And to conclude my talk, I believe the area, if you need to use a specialty balloon, is in-stent restenosis. Because in in-stent restenosis, you need to benefit from lumen gain. You cannot benefit from dissection and positive remodeling because the presence of the prior stent negate any possibility of positive remodeling. So achievement of an immediate good result is a must, and that's the reason why a specialty balloon is needed. There is this old study presented in 2015, more than 10 years ago, where they did scoring balloon before DCB for in-stent restenosis, and the restenosis rate went down to 35 versus 18. So from 40% to 35, and the binary stenosis from 32 down to 18. 32 with a standard balloon, 18 with a scoring balloon. And as Azim said, we have an array of scoring balloon available. Today we are focused on the DK score balloon, but I think you have a lot, and we need to compare one with the other. I don't know if we can afford to do all these trials, but definitely they need to be used. I think in the sake of brevity, this is the type of lesion that we challenge. Maybe the scoring balloon is not the answer here, but definitely we are going into that direction. Thank you.
Thanks, Antonio. Dr. Bin, did you want to make a comment or question?
Dr. Klum, thanks for your good lecture. I want to know what kind of special balloon would you like to use before DCB for prepare treatment?
Now we have our main experience is with cutting balloon, but to me the current limitation of the cutting balloon are the fact that it has some compliance, and we like to inflate the cutting balloon, and high pressure becomes not so predictable, and the deliverability, which has some limitation, even if it's better with the Wolverine compared to the standard cutting.
Thank you.
Maybe if I could ask a quick question to anybody in the panel who wants to answer it, very brief responses because we're running late. In your practice, when do you choose a cutting balloon versus a scoring balloon, or do you only use one or the other?
In my case, if the lesion is proximal or not. If it's proximal, probably a cutting balloon makes sense because the main issue for me is deliverability. If not, we can do both. But this is the main issue for me to select one or the other.
Okay. Anybody else? Louis?
Yes. So at our center, what the scoring balloon that we have is the angioscope, and I particularly like it in instant restenosis because you can bring it at much higher pressure than the Wolverine, which is the cutting balloon that we have. So in that particular scenario, I like the scoring balloon, but in the novel lesions, most of the time I go with a cutting balloon.
For us in Singapore, we mostly use scoring balloons. We're actually running a randomized controlled trial called the Score Cut trial.
Okay.
1-to-1-to-1 comparison, NC balloon versus NC Scoreflex trio versus Wolverine, looking at an IVUS endpoint. So we're looking at IVUS MLA, 196 patients, and we're looking at delta MLA.
Okay.
To see which one gives you the best luminal gain, and we're also looking at some secondary angiographic endpoints.
And what kind of lesions? I mean, are you looking ISR,
So we're looking,
calcified,
we're
everything?
looking at de novo 2 to 4 millimeter lesions prior to DCB angioplasty.
Okay, so they don't specifically have to be calcified.
Not specifically, no.
Antonio, what about you, quickly? When do you use cutting balloons versus scoring balloons? Or do you think they're interchangeable?
No, I don't think they are interchangeable. I think we prefer the cutting balloon, and we are really eager to start utilizing this DK balloon, which is more close to the cutting balloon approach than the scoring balloon.
So I think that's what fascinated me about seeing this balloon, is because I think, like many of you, we like cutting balloons because we, especially in calcified lesions, I think maybe it's more effective. We don't have randomized data, we'll see from your study, but the deliverability is a challenge. And sometimes I feel with scoring balloons, even though they're deliverable, you don't always get the result you'd like, particularly in a calcified lesion. So this balloon almost seems to me at times, I hate to say, like a hybrid between the two. It may give you very similar results, such as a cutting balloon, but with better deliverability.
Yeah, but I think in the presentation that follows, your point will be highlighted more.
So our next speaker, unfortunately, couldn't make it from China, so was kind enough to record his presentation. And since he has so much clinical experience with the balloon, we thought it was important for
Good afternoon, dear colleagues and audience from EuroPCR. I'm greatly honored to have this opportunity to share with you the results of this clinical study, which was mainly performed in our center. So this study was to evaluate the acute lumen gain and the device procedure success of DK scoring balloon versus NSE scoring balloon for patients with coronary artery stenosis. So I'm Zhijian Wang from Capital Medical University Anzhen Hospital. So I do not have any potential conflict of interest to report. So this study is a prospective multi-center randomized controlled trial which enrolled 200 patients from March 2021 to September 2021. So all the patients were followed up at 30 days. The primary endpoint of this study was acute lumen gain after procedure, which was defined as the difference in minimal lumen diameter of target lesion before and after dilatation by either arm device, measured by QCA. Secondary endpoints include device success rate, TIF rate, cardiovascular patient-oriented composite endpoint, incidence of related complication, and clinical success rate. So we only included relatively simple lesions, which includes de novo lesions and instant restenosis. CTO lesions, left main lesions, and thrombus lesions were all excluded from this study. So totally 4 cardiovascular centers in China was involved in this study. So all the 200 patients with coronary artery disease were 1-to-1 randomized into either DK scoring balloon or NSE scoring balloon. So the baseline characteristics between the two groups were all similar, we can see from the table 1. And there's no significant difference in the lesion characteristics, including reference vessel diameter, lesion length, and the diameter stenosis. The primary endpoint, the acute lumen gain, was much better in DK scoring balloon versus NSE scoring balloon, which was 1.12 in the DK score group and 0.95 in the NSE group. The p-value was 0.005. And we further take into a look at the performance of the DK score in some lesion types. We can see that the DK score has better acute lumen gain either in the instant restenosis or in the de novo lesions. The benefit is quite consistent. And all the secondary endpoints were all similar between the two groups. In terms of device performance, we can see that from the table below here, the DK score has significantly better pushability compared with NSE. And also DK score has a better acute residual stenosis after device dilatation, which also caused lower residual stenosis after PCI, although the difference is not statistically significant. So in summary, DK score, which is directional scoring balloon, has a better acute lumen gain and a lower residual stenosis with comparable safety rates compared with NSE balloon. And also DK score balloon has better pushability, which leads to higher technical success rates compared with NSE. So in the next few minutes, I would share with you two simple cases very briefly. The case one is a patient with exertional angina. The angiography showed that severe instant restenosis in the proximal right coronary. OCT also showed there's a stent here in the proximal right coronary and very severe intimal hyperplasia. So we first use a 2.5 DK score dilated at 10 to 12 atmosphere. Repeat angiography showed that the result is not so satisfactory. So we changed it to a bigger DK scoring balloon, 3.5, dilated at 12 atmosphere. So the final result was quite satisfactory. And OCT also showed the acute lumen gain is perfect, and there's no significant dissection here. So second case is a 74-year-old female patient with exertional angina within the recent 3 months, but the patient was detected pulmonary nodule 1 week ago, and the surgery operation is needed for this patient. But unfortunately, the patient received angiography and showed that severe stenosis in the middle LAD. The iris showed the minimal lumen area was only 1.87 square millimeter, which means that the patient needs revascularization before the operation procedure. But the best strategy for this patient is not to put any stent into the vessel. So to avoid dissection here, we begin with a smaller DK score balloon, which is a 2.5, dilated at 10 atmosphere here. Repeat angiography showed that the lumen is larger, but it's not good enough. So we further use 3.0 DK score balloon, dilated at 12 to 14 atmosphere. The final result was quite perfect. And the iris showed that the minimal lumen area was 2.08 square millimeter, which is much larger than pre-procedure measures. And there's no severe dissection here. So this is all my report. I'm very sorry that I cannot go to Paris to talk with you face-to-face. Wish all you guys have a great time in this wonderful meeting. Hope to meet you in Beijing in the future. And thanks for your attention.
Maybe if I can ask, some of the audience, because I'm just going to put this up, the actual balloon, because Those of you who've used it, because I think we've seen the balloon now in action, but I don't think people really understand how the balloon works or some of the features. So maybe, I don't know, Dr. Liang or Dr. Alfonso, who you've actually tried the balloon, maybe you want to make some comments on just how this balloon differs to other scoring balloons.
Well, for me, the main difference is that the scoring elements are inside 2 layers of the plastic thing in the balloon, so they are not attached. And this means that in the tortuosity that you have to face in this kind of lesions, these elements are always against the balloon. So not are separated from the body of the balloon. And also these elements are very flexible, so the deliverability of the balloon is quite nice. We tried in a very complex case in a distal right coronary artery, and it was amazing. Mm-hmm. And the rest is similar. The rest is similar in terms of the cutting elements, the expansion, and this stuff. Mm-hmm. I don't know if you have tried the balloon as well, or your practice with scoring balloons, you are undersizing 0.5 and then using high atmospheres. It's the same I do, but I wonder what...
So it's the same concept like we do with scoring balloons, 0.5 millimeter smaller, higher pressure. Anybody else who's had first-hand experience, Dr. Lau, you just want to comment on the balloon itself and your experience, or maybe some of the technical characteristics that make it different?
I think talking about, first I think it's deliverability. I think the nitinol coil, I'm not saying very tortuous we managed to cross, but some of the tortuous cases we thought that we couldn't cross, we managed to deliver smaller balloons. And I think the triangular scoring elements with the 120-degree fix, it gives it a very focal effect. And you can see that the focal effect, the balloon actually do open up some tough cases, tough calcified lesion. I mean, of course, not the 360 or calcium nodule, but those 270 with very heavy calcified. We do get quite good result with this balloon. We also have, I think we only had it in for about 7-8 months, but unfortunately, the government, Malaysia government had a recent tender, so it's actually been removed from our shelf last month.
I'm sorry.
So that's the unfortunate thing.
Okay, great. So maybe Dr. Lau will have you come up and give the last presentation, and we can again learn from your experience while you had the balloon before the government took it away. Sounds like you live in America.
Good afternoon. Thank you very much for the kind introduction. So I'll be talking about optimal lesion preparation with directional scoring balloon for stainless PCI. It's not a complex case. It's just actually a simple case. I just want to show how we prepare the lesion with control dilatation and control dissection. So I have a 73-year-old gentleman smoker, hypertensive dyslipidemia. His main complaint, he's a very active gentleman. He goes hiking almost every day. So he has exertional angina for the last 3 months, and it worsened. So he went to a private center, had a CTA done, and it shows proximal LAD. There was 70% stenosis. His echo was preserved ejection fraction, so he was referred over for further management. So we brought him to the cath lab. So you can see the diagnostic left seated, you can see a lesion at the proximal LAD. All right, and this is the caudal view, and RCA was a very ectatic vessel, but there was nothing to fix there. So we performed PCI to LAD, so we did imaging first. So this is what we got during our IVUS. If you can see, there is a tight lesion with an MLA of 2.98. Calcium, but there are cracks all along the calcified region there, area, the point the tightest point there, and you can see the vessel is calcified from mid to proximal. So we went up preparing the lesion with 3/15 DK score. So we went up initially 12, 14, and went up to 16. And next we increased the size to 3.5 because proximal it was around a 3.7 to 4.0 vessel. So we went up with a 3.5 and gradually went up to 16 atmosphere. And this was the angiogram after preparing with DK score. So we went in again with IVUS this time to look at the calcium, the preparation of the lesion, and you can see that most of the places, most of the area, and our place of interest was the tightest point there, and you can see at this point you can see cracks at 7, 11, and 2 o'clock. So the MLA actually went up to around 4.56. So if you see the difference, you can see the crack there at 7 and 11 and 12. So there were very minimal dissection. So we decided to proceed with DCB. So we put in a DCB solution 3.530 at 6 atmosphere for 60 seconds. So this was the final result, right? And right, so we brought him back to clinic, and after 6 months, he actually very asymptomatic. Actually, in our center, initially when we started using DCB, we do bring patient back for relook, especially those that we need to stage the right side. Definitely will not do the same setting because we want to bring them back. When while staging, we will have a look at the left system where we actually put in DCB. So recently, because most of our patients do well, we stopped doing that. But this patient, during clinic, we actually asked him, he asked us a question, since you put in a balloon, do I need to actually reassess? So we actually offer him, but in view that he was actually very asymptomatic, he's back to his regular activity, so he actually declined it for now. So a little bit on the balloon, as mentioned earlier, it has a patented nitinol coil wire, which actually have higher strength and flexibility for deliverability, and the triangular scoring elements, which has high focal force and cutting depth, and the 120 distributed fixed scoring element. All right. So with that, thank you very much for attention.
Thank you so much, Dr. Lau. So can I ask, I mean, in your practice, just so we understand, what percentage of cases do you do with DCB?
As high as 40 to 50% now.
Okay. And in what percentage of cases do you use a specialty balloon, whether it's scoring or cutting, on average?
Average, I think more than 50% we use scoring.
Okay.
And when we talk about DCB, actually, when I say 40-50%, out of the 40-50%, probably 50% we go for hybrid also. Okay. We do a lot of hybrid now.
Hybrid. So. Okay, great. Thank you. Come have a seat, please. Thank you. So
I have a question for whoever wants. Do you think our approach maybe is wrong? Our approach is most of the time to try with a regular balloon, non-compliant balloon, and then if the result is not acceptable, go to a specialty balloon. Is this approach wrong? You may get more unfavorable dissection if you go first with the non-compliant balloon at high pressure. Should you first try with a specialty balloon, especially if you want to use the DCB and not to implant a stent?
I think that's a great question. So let's maybe go around the panel, and let's start here next to you, Antonio. All right?
Yeah, I think our sort of algorithm when we're approaching lesions that we're going to DCB is you kind of have to decide whether the specialty balloon can cross the lesion. So if you've got a very tight lesion, most of the time I do pre-dilate with the smaller balloon, maybe a compliant balloon, and then deliver the specialty balloon. We use a lot of specialty balloon, a bit like Glendon. We do about 40% of our PCI drug-coated balloon, and probably about 50-60% we do use specialty balloons. Cost is an issue as well because the cutting balloons are twice the price of the scoring balloon, and the scoring balloon is 5 times the price of the NC balloon. So, there's a cost implication as well for us in our health system, and so being judicious about that, and in certain, particularly if you do intracoronary imaging, you understand the plaque morphology you're dealing with. Certain times you may be able to get a successful luminal gain with an NC balloon and may not need a specialty. So I think it's situational.
Yeah. I'm often surprised when I hear some of our German colleagues talk about DCBs, and I've heard 1 or 2 of them say they use cutting balloons or specialty balloons in every case. But again, I think it's health system dependent because costs, right? Louis, what about you? I mean, when you see this technology that, more deliverable, you already, like scoring balloons, where do you see this in your practice?
Well, what I like the most about this new balloon is the non-compliance. We undersize all of our Wolverine because we go so high pressure with it.
Yeah.
Regularly 18, 20, up to 24 atmospheres sometimes, but because it's a compliant balloon, you're kind of guessing the size that you're going to have at this such high pressure. So having this tool, you can go up to 20 atmospheres without, and what size balloon you have. I think it's going to be a game changer.
Right. And so, I mean, Louis, you do a lot of complex cases and complex lesions and so on. I mean, and I know I have to, in America, we pay $5,500 for a drug-coated balloon. Anybody wants to come sell balloons in America? It's a good place to come do it. So I have to stop Louis sometimes, say, slow down. You can't use 3-4 balloons in one patient. But you do a lot of complex lesions. I mean, where do you see, based on what Antonio said, I think we sometimes make the lesions longer or more complex, the procedure, by going first with the NC balloon. It's not dilating well. Then eventually we go to the scoring balloon. I mean, here, if you had a device that's much more deliverable, where do you see the role in your practice? You do CTOs, you do calcified lesions, you're doing a lot of DCB-only cases. Do you see, which way do you see the role of doing a specialty balloon as intention to treat, like right front, your first balloon?
Yeah, I mean, having it, I've never used it, but it sounds like it's a very deliverable balloon, so I might go, with that balloon first, much more in the future. Mm-hmm. Right now, with the Wolverine, you have to kind of make some space to get it through the lesion and be able to, deliver it to the intended treatment area. So having a balloon like that it's very deliverable, I think it might very well be my first balloon when we have it.
The problem of the cutting balloon is not always the profile, is the flexibility. So sometimes, even if the lesion is down distally, but you have to go through quite a rigid proximal segment, becomes difficult to get the device there.
So, Alfonso, it sounds like you have lots of different balloons on your shelf, specialty balloons, because you've also tried this balloon. You have Wolverine, you have angiosculp, I'm sure you have a scoring balloon. How do you choose? I mean,
it depends. We don't have this issue of the reimbursement in Spain is different, and also the drug-eluting balloons are much more cheaper than in New York. But taking the point of Professor Colombo, I think that it depends on the scenario, the lesion you are treating, and your final therapy, your final strategy. If my final strategy is using a drug-eluting balloon, make a lot of sense starting with a balloon like this instead of an NC balloon, because you can deliver, it's more flexible, and you try to get the drag of the balloon there. If you are you are in another scenario in which your non-compliant is not expanding, probably it's another field. Probably you need a lithotripsy balloon or something different. But it's different for me if your final therapy or initial strategy is a drug-eluting balloon or drug-eluting stent, in which lesion are you treating?
Right. Any final comments from the panel? Dr. Lau, any final comments? No?
I think as shown in my case, as mentioned by the panelists, if upfront I think this is a DCB case, then I will upfront use a special balloon. And I think in Malaysia DCB the price is same like a DES, so we don't really have problem using.
Well, I think what you both said is an important statement, because I think it's almost a paradigm shift. These specialty balloons are not specific for calcified lesions.
Yeah.
They are specific for DCB preparation. I think it is very important.
Yeah, absolutely, absolutely. So I think, we've come to the end. Dr. Bin, you want to give us some take-home messages and wrap up?
It's my pleasure to be here to attend the wonderful meeting. And I think scoring balloon are very useful for pre-treatment before stent or DCB. Some new generation scoring balloon have some advantages. First is the new scoring balloon create controlled precise insection. I think this is really very important, because it helps us to reduce the very serious dissection during the procedure. Second is the deliverability. New scoring balloon have very good pushability, flexibility, and excellent deliverability. I think in some situations, such as very tortuous or calcified lesions, for some scoring balloons, such as the cutting balloon, not easy to pass over. But for new generation, it's all easy to pass over. The third is new balloons have very high burst pressure, up to 20 atmosphere. So for some very tough case, such as very tough calcified case, the new generation may be useful. Yes. I think another thing we are also concerned is about safety. The new generation scoring balloon, the wires are bonded to the balloon surface. So we don't worry about the wires will be entrapped inside during the procedure. So yes. So I think scoring balloon is useful, especially for some complex PCI. Thank you.
The point is not only regarding the balloon breakage. If the wire is not attached to the balloon surface, it may happen that the wire get embedded into the plaque or the calcium, and when you deflate the balloon deflates, but the wire does not come back.
Yeah, absolutely. I mean, the one thing we never spoke about during this, Antonio, and I'm going to ask you to make the final comment, is safety and perforations. I mean, you mentioned the COP study. I mean, there was a slightly higher perforation rate numerically in the cutting balloon arm versus the non-cutting balloon arm. Do you want to maybe talk about, safety with these different balloons?
We are always afraid to use, for example, cutting balloon at high pressure after rotablation. I think one of our worst perforations were in those settings. And I think the point that you made regarding high pressure, semi-compliant balloon becomes unpredictable. And sometimes the fact that the blades are straight and are not conformable may be another issue. So I think, but all these questions, we need to use this balloon more and more. And maybe next year we will have some some data.
Excellent. Good place to end. Thank you so much.
Thank you.